Hello everyone, welcome back. Today I'll be covering my note on Legg Calve Perthes disease, LCPD, and overview, journal number 6 by Armando O. Rodriguez et al. 2022. A part 1 video. These include background, pathogenesis, stages of Legg Calve Perthes disease, stage 1, necrosis phase, Stage 2, fragmentation phase. Stage 3, re-ossification phase. Final phase, healing or residual deformity. Differential diagnosis. Diagnostic criteria based on clinical and radiological diagnosis. And classification used. Now, let's get started. Background. The Legg Calve Perthes disease, LCPD, is characterized by unilateral or bilateral necrosis of the femoral head, which impairs the range of motion of the hip. It usually appears from the age of 3 to 12 years old, the commonest age between 5 to 7 years old. Boys are commonly affected. The disorder is bilateral in around 10 to 24% of patients. A correlation to inheritance in around 8 to 12% of patients. Pathogenesis. From a mechanical point of view, deformities in the femoral head will occur when the forces applied to the femoral head are greater than its capacity to resist deformation. First, in the avascular stage, the calcium increase in the necrotic bone makes it more prone to micro damage, which compromises the mechanical properties of the femoral head. Necrosis will lead to a decay of bone cells, osteoclasts and osteoblasts, causing microfractures to remain unrecognized and or unrepaired. Then, during the revascularization stage, the necrotic bone will be resorbed, further compromising the mechanical properties. This picture shows a necrotic bone prone to micro damage. Legg Calve Perthes disease stages. Stage 1. Initial or necrosis phase. Characterized by interruption of vascular supply and bone necrosis. At this stage, the femoral head is very vulnerable to the forces acting on it. Radiologically, the Waldenstrom sign is visible, which is characterized by increasing joint space. Secondary to a subchondral fracture, this is the earliest radiological sign. This X-ray of the pelvis shows a frog leg view. The Waldenstrom sign is visible, whereby there is an increase in the joint space secondary to a subchondral fracture. As you can see, the head looks smaller compared to the other side. Stage 2, fragmentation phase. It is characterized by, started off initiated by a process of resorption of necrotic bone. Radiologically, dense bone islet appears. The central ones are condensed and the lateral ones undergo osteolysis, producing an image with multiple lines. This X-ray of the left hip shows the stage 2 fragmentation phase. There is a resorption of the necrotic bone. Stage 3, re-ossification phase. It is characterized by where the density is displaced in the opposite direction, The epiphysis is invaded by vessels. The dense inslets are reabsorbed and irregular bone tissue is formed, which then trabeculates, and repair begins with the disappearance of the metaphyseal osteolysis. This figure shows the stage 3 of re-ossification or reparation stage. Final phase of healing or residual deformity. It is characterized by the necrotic bone is completely replaced by a new formed bone. The newly formed bone has a lower rigidity, so it can be remodeled in such a way that the morphology of the femoral head adapts to the shape of its insertion hole or not. This process will not be definitive until the end of bone maturation. The result may be a deformed femoral head. Again, the X-ray of the left hip shows the final stage or the heel stage or the residual deformity may form. As you can see, it is a heel stage. The duration of each stage is variable, but in general, the necrosis and fragmentation stage lasts about 6 months to 1 year. The re-ossification stage from 18 months to 3 years. Some authors said around 3 to 5 years. The final phase until bone maturation. The differential diagnosis of Perthes disease. These include transient synovitis, Meyer dysplasia, epiphyseal dysplasia, spondyloepiphyseal dysplasia, chondroblastoma, juvenile idiopathic arthritis, drug-induced femoral head necrosis, Koch's disease, sickle cell anemia, thalassemia, achondroplasia, Klinefelter syndrome. Diagnostic criteria based on clinical and imaging studies. If based on clinical features, pain is primarily localized in the hip, occasionally accompanied by leg and knee pain. Most of the patients show limited hip internal rotation. Patients often have a history of practice of high-impact sports or smoke exposure. If the diagnostic criteria based on imaging studies, A. Start off with X-ray imaging, anteroposterior and frog leg positioning view. The commonest used in Perthes disease. The findings of osteosclerosis, cystic change, and a crescent sign in earlier stages. After collapse, there is loss of sphericity of the femoral head and degenerative arthritis in the late stage. This X-ray shows a crescent sign in fragmentation stage. B. Magnetic resonance imaging MRI. MRI may show proximal femoral abnormalities before radiography in the setting of Legg Calve Perthes disease, allowing appropriate diagnosis and prompt treatment. MRI can also assess for revascularization, healing, and shows complication. MRI has high sensitivity for osteonecrosis of the femoral head. It shows as a limited subchondral linear-shaped low signal intensity in T1 weighted images, T1W1, or a double line sign in T2 weighted images. This MRI of coronal T1 weighted shows flattening and fragmentation of the left proximal femoral ossific nucleus, labeled as arrowheads, as well as mild loss of containment. All ossific fragments show abnormal signal hypointensity. Or C. Computed tomography CT scanning usually reveals the zones of osteosclerosis surrounding the necrotic bone and repaired bone, or shows the subchondral bone fracture. This coronal CT scan of the pelvis shows there is flattening, sclerosis, and early fragmentation phase of the right femoral head. Classification. In order to predict the prognosis and decide on the appropriate treatment, certain classification use helps in the decision making. A. Caterall in 1971 divided the disease into 4 grades according to the extent of the epiphyseal lesion. In type 1, 0 to 25%, type 2, 25 to 50%, type 3, more than 50%, type 4, 100% involvement. This figure shows the Caterall classification in frontal and axial view. The Caterall classification is based on extent of epiphyseal lesion. So the frontal or AP view shows 0 to 25% involvement, 25 to 50% involvement in type 2, 3 more than 50% and less than 100%, 4 100% involvement. In 1984, Salter and Thompson described a classification of 2 groups, A and B, which defined by the extent of subchondral fracture visible on axial radiograph in the early stage of the disease. This is based on the radiographic crescent sign. Group A, including the Caterall group 1 and 2, where the crescent sign involved less than 50% of the femoral head. Group B, including the Caterall group 3 and 4, where the crescent sign involved more than 50% of the femoral head. The disadvantages is not all patients are diagnosed at an early stage. This figure shows the Salter and Thompson classification. As you can see, A shows crescent sign less than 50% of the femoral head. B shows the crescent sign more than 50% of the femoral head. Another classification by Herring 1992. It is based on the height of the lateral pillar of the femoral head epiphysis in the fragmentation period of the disease and is divided into 3 groups. Group A, there is no involvement of the lateral pillar and its full height is maintained. Group B, height loss is less than 50%. Group C, height loss is more than 50%. The predictive value of the Herring classification is higher in the early stages of the disease. Recently, there is a 4th group being proposed between the group B and C, in which the lateral abutment is narrow, poorly ossified, or maintains 50% of its height. So this figure shows the lateral pillar classification based on the height of the lateral pillar of the femoral head epiphysis in the fragmentation phase. You can see A. There is no involvement of the lateral pillar and full height is maintained. B. The height loss is less than 50%. C is height loss more than 50%. And the fourth group between the group B and C, where there is a lateral abutment is narrow, polyossified, or maintains 50% of its height. Additional notes. What is head at risk sign? Among the common questions being asked during my final exam. 1. Calcification lateral to the epiphysis. 2. Radiolucency in the lateral portion of the epiphysis. 3. Horizontal proximal femoral physis. 4. Metaphyseal engagement. 5. Lateral subluxation of the femoral head. This figure shows the head at risk sign. We revise again. 1. Calcification lateral to the epiphysis. 2. Radiolucency in the lateral portion of the epiphysis. 3. Horizontal proximal femoral physis. 4. Metaphyseal engagement. And 5. Lateral subluxation of the femoral head. Yay! We have reached to the end of this video. See you in the part 2 video. Take care and bye.